Hello, a very good evening, students. Hello, Kalyan. Okay, so we are back with the Farre series, your fourth prof exam questions, and a very important topic. Good evening. Good evening, everyone. We are going to discuss a very important topic today, nutrition, malnutrition, and breastfeeding. In the previous lecture, we discussed about micronutrients in health and disease. Here, we are going to discuss breastfeeding, breast milk, and malnutrition. This is an overlap topic with the community medicine. So, whether you are giving your community medicine exam or pediatrics exam, be it theory, be it viva, there is a short chance that they are going to ask either malnutrition or something about breast milk and breastfeeding. So let's start. Firstly, we are starting with pediatrics, malnutrition and breastfeeding. So what is malnutrition? Can anyone tell me what is malnutrition per se? Malnutrition, whenever you hear the term malnutrition, what do you think? The immediately the picture comes to our mind of a cachexic child, right? A very deprived child. But remember, malnutrition means both. Malnutrition covers both. It covers both undernutrition as well as overnutrition. So under as well as overnutrition. Under as well as overnutrition. But here in India, in developing country like India, more problem is that of an undernutrition, not overnutrition. That's why we use these terms malnutrition as well as undernutrition synonymously. So whenever someone asks you about malnutrition, remember it includes both under as well as overnutrition. But here in India, we use synonymously it with undernutrition because undernutrition is more problem over here than overnutrition. So with malnutrition, what is important are some of the definitions. This examiner can also ask, and these are the terms that you are going to hear here and there. So whenever we talk about parameters of growth, then anything that is beyond plus minus 2 standard deviation of the normal, plus minus 2 standard deviation, that is abnormal. So remember as a thumb rule that anything that is beyond plus minus 2 standard deviation is going to be abnormal. And definitely, obviously, if something is beyond plus minus 3 standard deviation, that is going to be severely abnormal. So if the weight of the child is in between plus 2 to plus 3, this child will be overweight. But once this crosses plus 3, that would be an obese child. Similarly, if it is between plus 2 to plus 3, it will be a wasted child. But minus 2 to minus 3, that would be a wasted child. But if it is beyond minus 3, that will be a severely wasted child, right? So remember, anything beyond plus minus 2 standard deviation is abnormal. But anything beyond plus minus 3 standard deviation is going to be severely abnormal, right? So with that, let's learn some of the definitions. Firstly, we have weight for height. Weight for height minus 2 to minus 3 standard deviation. So this child is going to be wasted or severely wasted? This child is going to be wasted. This is wasting, definition of wasting. But if it is less than minus 3, this will be severe wasting. Severe wasting. Then comes height for age. If the height of a child is shorter, that means this child is stunted. The child has short stature. So if the height for age is in between minus 2 standard deviation to minus 3 standard deviation, this child will be stunted. So this is stunting. But if it is less than minus 3 standard deviation, this is severe stunting, right? On the other hand, if weight is on the higher spectrum, weight for height is in between plus 2 to plus 3 standard deviation. Will this child be overweight or obese? Definitely this child will be overweight. If it crosses plus 3 standard deviation, this will become an obese child. So if you remember this concept that anything beyond plus minus 2 is abnormal and anything beyond plus minus 3 standard deviation is severely abnormal, you can easily get a hang of all of these definitions. So with that, let's move on to the next concept of acute and chronic malnutrition. What is acute malnutrition? What is chronic malnutrition? Acute, you all understand, for a shorter duration of time. So if you deprive the nutrients of a child for a short duration of time, maybe some stressful period happened, that leads to acute malnutrition. For example, when you move to your MBBS college from your home, if you're not a day scholar and you're moving to your MBBS college, which is very far away, and you're having hostel food, then definitely in the first week, you lose some weight, right? Because you're not getting that good nutrition that you were getting at your home. So that is acute phase. But if the nutrition is deprived for a long period of time in a child, what will happen? The weight will be decreased, but the height of the child will also not increase. That means the child's height would also be affected. So that's the basic concept behind the differences between acute and chronic malnutrition. In acute, only acutely the weight would be affected, but in chronic, the overall development, the weight, the height of the child would also be affected. So let's look at the differences. Firstly, weight for age. I know in both acute and chronic malnutrition, in both of the scenarios, weight for age will be less. What about height for age? If the malnutrition is the stressful period is for a short period of time, acute malnutrition, then the height for age would be normal. Height for age would be normal. But in chronic malnutrition, the height for age would be decreased, right? Same goes for weight for height. I know in acute malnutrition, weight is decreased, but the height stays normal. So weight for height, the ratio would be decreased. Weight for height, the ratio would be decreased. What about chronic malnutrition? Weight is also decreased, height is also decreased. So weight for height, that ratio may be normal over here, right? So it may be normal over here. What about BMI? How do we calculate BMI? Weight in kgs divided by height in meters squared. So this is BMI. This is very similar to weight for height. So again, the same pattern will follow over here. Now the questions they can ask in the exam. They ask which is the marker for acute malnutrition. If you see over here, weight for height is the marker for acute malnutrition. This is the marker for acute malnutrition. Best marker for acute malnutrition. What about chronic malnutrition? We all understand height is affected in chronic malnutrition. So height for age, this is the marker for chronic malnutrition. Marker for chronic malnutrition. And what is common to both of these? What is common to both of these? Weight for age is common to both of these. Right? This is common. This is common to both. Common to both acute and chronic. Right? So these are the basic differences between the acute and chronic malnutrition that are asked in the exam. So make sure you make up this table and be very wise and very rapid while answering these questions in the Viva. So an examiner can very well ask you that which parameter is common to both acute and chronic malnutrition. Which marker would be best to identify if this is an acute malnutrition? Which marker would be best to identify if it is a chronic malnutrition? Right? And all of these parameters could be asked in the exam. With that, let's move to the next topic, that is extreme forms of malnutrition, Kwashiorkor and Marasmus. Age-old question, they can ask the differences. Similarly, after your prof, if you're appearing for exams like INI, CT, NEET, PG, and even for the candidates who will appear for FMG exam, this is a hot shot favorite topic of all the examiners. Extreme form of malnutrition, Kwashiorkor and Marasmus. In both of these, the child has extreme malnutrition. But one child behaves differently. One child will become very thin, skin and bones baby. One child will become very edematous, listless, lethargic, and has poor prognosis. So why in both of these the underlying pathology is very different? Both of these are deprived of nutrients, but both are behaving very differently. So there are two hypotheses to tell us why they are behaving such differently. The first hypothesis is adaptation hypothesis. Adaptation hypothesis, the other name of this hypothesis is Gopalan's hypothesis. Gopalan's hypothesis. So what this hypothesis says, the name itself says adaptation. So they say out of these two children, the one that adapted well to this deprivation of nutrients is a Marasmus child. And if the adaptation is poor, this becomes a Kwashiorkor child, right? So Marasmus child, the adaptation is good. Good adaptation. This child well adapted to the surrounding deprivation, right? This child adapted very well. So he used up all his body fat for the nutrition. Good adaptation. Whereas Kwashiorkor has poor adaptation skills. Instead of using all the resources the body has, the physiology gets altered, the child becomes edematous, lethargic, will not accept even more food. So this is about the first hypothesis, that is adaptation hypothesis. Okay, let's move to the next hypothesis, that is free radical injury. So the first hypothesis I told you, Gopalan's hypothesis, adaptation hypothesis. The second hypothesis is free radical hypothesis. This is also known as Golden's hypothesis. What this hypothesis says? This hypothesis says whenever the body is in a stress-like condition, free radicals would be generated. And to combat this free radical injury, our body has antioxidant mechanisms. If the antioxidant mechanisms are good, my body will stay fine, body will stay protected. So this happens in marasmus. So if you have good antioxidant mechanism, the child will have marasmus. On the other hand, if the antioxidant mechanisms are poor or bad, that will lead to Kwashiorkor child, right? So now let's look at these two children. Child A and child B. Look at child A. Child A. Looking very thin, very slim, right? Skin and bones. Can you see the bones of the baby? It looks as if there is no fat underneath the skin, no muscle underneath the skin. It looks like a skin and bones baby. Just the baby who's made up of skin and bones. A very cachexic child. And look how alert he is sitting. If you will offer food to this child will readily eat the food. Very hungry looking child, right? On the second side, child B. Look at the child B. What is happening to this child B? This child B is looking swelled up. This child has become edematous, and this child is not at all alert. He's lying down listlessly over the bed, right? If you offer food to this child does not has a good appetite. The child will not have this food. Which of these has good prognosis? Child A has good prognosis. On the other hand, child B is going to have bad prognosis. So child A is nothing but your marasmus child who adapted well to the deprivation. On the other hand, B is a Kwashiorkor child. So now examiner can ask you to write down a short note on Kwashiorkor, short note on marasmus, or can ask you the differences between marasmus and Kwashiorkor. So we are going to deal with this topic now in depth. Firstly, let's start with Kwashiorkor. What is the hallmark of Kwashiorkor? Remember this Motu baby child B? So what is the hallmark? Why just by looking at this baby you can say this is Kwashiorkor? This baby looks edematous, right? Edema is the hallmark of Kwashiorkor. So, what is the hallmark? Hallmark is edema. Now the question comes, why this edema has developed? So there are three particular reasons for that. The first reason is diet, obviously. The diet is very low in proteins. So there is hypoproteinemia. So if the proteins are less, what will happen to the oncotic pressure in my vessels? That will decrease, and there will be edema, influx of fluid into the extracellular space and edema. So the first reason is hypoproteinemia. Right? Also, these children, because their physiology is altered, even if you give protein from the outside, their gut is now not absorbing well. So there is decreased protein absorption. Thirdly, whenever there is edema in our body, for example, if you sit and study for long stretch of hours, what happens? Your feet become edematous, and then you walk down, lie down, and that edema disappears. So what system in our body is making that edema fluid go? Which system in our body is clearing that edema fluid? We all understand it is the lymphatic drainage system. So lymphatic drainage system, it clears out that edema, makes sure that the circulation goes long. But here the lymphatic drainage is also impaired. There is impaired lymphatic drainage. So if the examiner asks you why this Kwashiorkor child is edematous, you tell the three reasons. So there is hypoproteinemia, there is decreased absorption of proteins, and the lymphatic drainage is also impaired. Right? So this is all about the first hallmark, edema. The second feature, how was the child looking? Was the child looking alert or very dull looking? The child was looking very lethargic, very dull. I told you this child is impacted by poor nutrition, so this child is going to have growth retardation. What else? What else? What do you think about the muscle mass over here? Is the muscle mass good or bad? Though this child is looking very edematous, very chubby to you, but the muscle mass here is impacted. There is muscle weakness, muscle wasting. But this is masked by edema. Because of the edema, we cannot see that how wasted the muscles are. Right? So there is going to be muscle wasting. This is masked by edema. Okay, so these were the hallmark features of Kwashiorkor. Also in Kwashiorkor, in fact in Marasmus also, we see this certain skin and hair changes. These skin and hair changes are seen in both Kwashiorkor also, Marasmus also, but they are more appreciated in Kwashiorkor, right? Remember, these changes can be seen in both extreme forms of malnutrition, Kwashiorkor as well as Marasmus. But if you have to choose one, choose Kwashiorkor. They are more commonly seen in Kwashiorkor children. So let's see what are these skin and hair changes. Look at this image. Firstly, hair. Can you see there is area of hypopigmentation, less pigment, lighten hair? Then we have normal pigmentation or hyperpigmentation. Then again we have hypo, then hyper. This areas, the patches of hyper and hypopigmentation in the hair is known as flag sign. Flag sign. Look at the second image. What is happening over here? In the second image, there is peeling of the skin. Peeling of the skin, as if some paint is coming out of the wall. If you have seen some older wall or just a wall that has been damaged by water, monsoon season, you see paint chipping off the wall. This is known as flaky paint dermatosis. The skin peels off and looks as if there is flakes coming off of the skin. So this is flaky paint dermatosis. Flaky paint dermatosis. What about the third condition? Again, areas of patchy areas of hyper and hypopigmentation in a pavement like pattern. You have seen the pavement, the tiles that are broken down and attached on the floor, pavement, to make a pavement, crazy pavement appearance. This is known as crazy pavement appearance. So remember, these are the three skin and hair changes that you appreciate in this extreme forms of malnutrition. First was the flag sign, that this is seen in hair. Then we have flaky paint dermatosis. And then we have crazy pavement appearance. Crazy pavement appearance. With that, let's move down to how you're going to answer the question of differences between Kwashiorkor and Marasmus. Kwashiorkor we have discussed in detail. Marasmus would be very easy to follow up now. So firstly, tell me wasting, muscle wasting. In Kwashiorkor, do you have muscle wasting or not? The baby is looking very chubby, but there is muscle wasting. That muscle wasting is masked by edema, right? So we have wasting over here, but this is masked. There is masked by edema. What about Marasmus? Marasmus child, remember, very cachexic, very thin child. So the wasting is very visible. You can see skin and bones, right? So wasting is there, and this wasting is very severe, visible wasting. Very severe, visible wasting. What about the onset? Kwashiorkor. Usually Kwashiorkor is seen after 1 year of age, when the diet is predominantly switched to a low calorie diet. So onset is usually after 12 months of age. Marasmus you can see at any time, even before 12 months of age. The predominant deficit here is the protein deficit. Here it is the overall calorie deficit. Now coming to the appearance, you can very well tell what was the appearance in Kwashiorkor baby. Edematous, chubby baby, looking very dull to you. So general appearance is very dull and this baby is looking overall very chubby. So it is a fat sugar baby. Fat sugar baby. It is called as a fat sugar baby. On the other hand, Marasmus child was very alert sitting. So this child is alert. And how was the child looking? Skin and bones. So this is known as skin and bones baby. Skin and bones baby. Now coming to the appetite, how was the appetite of Kwashiorkor child? The Kwashiorkor child was lying down listlessly. If you offer food to this Kwashiorkor child, this child won't eat the food, won't have much appetite. So the appetite here in Kwashiorkor is very poor. Whereas on the other hand, Marasmus child, that cachectic child, if you offer food to that child, the child will very voraciously eat that food. For example, if a child, a normal nutrition child of a normally nourished child of that particular age is having one chapati, this child can even have 4 chapatis. Such a big appetite this child has. Good adaptation. If the child gets some nutrition, the child won't let it go. Child is going to have a voracious appetite. So good appetite, in fact, a voracious appetite will be there. What about the prognosis? Marasmus child, physiology has altered, the child has developed edema, child is not having any food. So definitely the appetite here is very poor, bad prognosis. On the other hand, the prognosis here is a good prognosis. In Marasmus child, the prognosis is good. Additional features, we discuss skin and hair changes. And also these children will have a fatty liver, On the other hand, a Marasmus child has shrunken liver. This child is using all the resources that are available in his body. So there is shrunken liver. So these are the major differences between Kwashiorkor and Marasmus. If you make this table in the exam, I can assure you, examiner will give you full marks in that question because each and every point is covered thoroughly over here. Additionally, if it is a long question, you can explain in detail about Kwashiorkor, why edema is there, what are the skin and hair changes, and that's it. Right? So with that, we have come to the next topic, that is SAM, Severe Acute Malnutrition. So SAM is such a topic that will never leave you. If after your MBBS you go on doing MD or DNB in pediatrics or DCH, or if you go towards pediatrics, then definitely this will follow. And even in SS exams, this is going to follow. So SAM is such a topic that is hot favorite of examiners. You can get short notes on SAM, long questions on SAM, management of individual complications in SAM. So without further ado, let's begin with this topic, that is SAM, Severe Acute Malnutrition. So the first question the examiner is going to ask, define SAM. What is the definition of SAM? So remember, what is the definition of SAM? We say this child has SAM, that is severe acute malnutrition, if any one of the following is there. Anyone. We need only one. Any one of the following. What anyone? Firstly, there should be severe wasting. What do you mean by severe wasting? Weight for height less than -3 standard deviation. Remember, anything to be severe, it has to cross +-3 standard deviation. So severe wasting would be less than -3 standard deviation. So this is visible severe wasting. Sorry, this is severe wasting. This is severe wasting. The second thing is MUAC, mid-upper arm circumference. So if mid-upper arm circumference is less than 11.5 centimeter, this is SAM. And obviously we all understand this MUAC we've seen only 6 months to 5 years of age children. 6 months to 5 years of age children. So this criteria would be applicable for 6 months to 5 years. And the third is there should be bipedal edema. This is nutritional edema. You rule out other causes. So I need only one. If their child is severe wasted, it is SAM. If the child has bipedal edema and you have ruled out all other causes, this is SAM. If in an age group of 6 months to 5 years you see MUAC below 11.5 centimeter, this is again SAM. So remember, you need any one. I don't need all the three. I need any one to label this child as SAM. So imagine you receive such a child in your OPD. What are you going to do? Are you going to admit this child or you are going to treat this child at home? That depends upon whether this child that is coming to your OPD is a complicated SAM or an uncomplicated SAM. So let's understand the differences between complicated and uncomplicated SAM. Firstly, uncomplicated SAM. This uncomplicated SAM, obviously complications are not there. So I can send this child home. This child has a good appetite. Also, this child does not have edema. Also, this child has no medical complications. That's why we are going to manage it at home. So, this child is going to pass the appetite test. It has a good appetite. No edema is there, no medical complication there. So, we can go for home management. On the other hand, a complicated SAM has poor appetite. So, this child is going to fail your appetite test. There could be presence of edema, presence of medical complications. This child has to be managed in the hospital setting. So you're going to go for hospital management, right? So examiner can ask you, tell me the differences between a complicated and uncomplicated SAM. And furtherly, the examiner can ask you the management of uncomplicated SAM. So the uncomplicated child who was a SAM child but does not have edema, does not have any medical complications and has good appetite can be managed at home. So how will you counsel this child and how will you manage this child? Right, so firstly, let's start with home management of SAM. This is a child who has uncomplicated SAM. So what are the major points here of the management? 4 points. Firstly, I know this is a malnourished child, even severely acutely malnourished child. So this child needs nutritional management. We need to focus on the nutritional assessment and nutritional plan. Then we have 4 A's that we are going to discuss. Then sensory stimulation, and lastly but not the least, we are sending this child home. So you need to follow up whether this child is improving or not. So home visits for the child, for the nutritional assessment, for the anthropometric assessments. So firstly, let's start with the nutritional management of this child. So what you are going to tell about the caretaker to this child? Definitely this child now needs more calories. So you tell the mother or the caregiver that this child now needs more calories. How many calories are to be required? We say 175 kilocalories per kg per day. And in this calorie, proteins should be 4 to 6 grams per kg per day. How this mother is going to give or caregiver going to give this much calories and proteins? By home cooked meals only. Home cooked meals have to be prepared and have to be energy dense. So home cooked, energy dense meal. How the mother is going to make the home cooked meal energy dense? Earlier, if the child was having one chapati, now the mother can add on ghee and make it into a parantha. That will have more calories, will be more energy dense. For example, if the child is from the south and having idlis, you can increase the number of idlis and add ghee podi over it. That will again make it more nutritious. So by this, in your dal and sabzis also, you can add additional ghee to it to make it more energy dense. So this way, the home cooked meals can be made energy dense, right? And mother can be counseled how she can alter the normal food that is cooked in the house and make it energy dense for the child. If this home cooking and making energy dense is not economical or not plausible, for example, if there is a family of 8 members and both mother and father are working, maybe say they are belonging to a very poor socioeconomic status, both are laborers and they don't have that much resources to make the food energy dense or to cook the food even, then in that case we have one Brahmastra. What is that Brahmastra? Can you see this child? What is this child having? This red and white packet looks like a KFC logo packet, but this is nothing but RUTF. If home cooked meals are not plausible, then we give this RUTF. What is RUTF? Ready to use ready to use therapeutic food, right? Ready to use therapeutic food. This ready to use therapeutic food, what is the advantage? Can you see the packet? This is ready to use. It does not require any preparation, does not require any refrigeration. So a child can just tear up this packet and eat it. So what is the advantage? No preparation is required. No refrigeration is required. So if the mother cannot cook food at home, we can supply these packets to this child that have these packets into it. Can you see this packet? What do you think? What are the components of this packet? This packet is actually very tasty, very sugary peanut paste. Basically, peanut is poor man's protein, high in protein and cheaper. So this basically has peanut paste. Peanut paste has sugar to make it palatable, very tasty, has vegetable oil and milk solids. If you add sugar and oil to anything, it becomes very tasty. So the preparation is such, it tastes actually like a chocolate, right? So peanut paste, sugar, vegetable oil, milk solids, and along with that vitamins and minerals are also added. What do you think? What would be the protein and the calorie in one such packet? This is a small packet, but this packet has a lot of calories. The normal meal that you and me eat every day, the basic meals, not some fancy meal. The basic meal, the dal, chapati, sabzi, roughly a single meal of ours is 350 to 400 calories. If you are very adventurous, it can go up to 450 calories. But the small 100-gram packet has 543 calories, 543 kilocalories and 15 grams of protein. Right, so such energy dense is this RUTF, and because of the addition of sugar and vegetable oil, this is very palatable. So children usually eat it very well. So this is how you're going to take care of the nutritional aspect. The first point, nutritional management. Now let's come to the second point, that is 4A's. 4A's. What are the 4A's? First A. First A stands for antibiotics. Antibiotics. Because this child is a SAM child, we assume that because this child is deprived of the nutrition, this child is more prone to catch infection and does not have enough capacity to fight infection. So prophylactically, we give antibiotics. We give oral amoxicillin for 5 days. Now let's talk about the second A. The second A is albendazole. Deworming. What is the dose of albendazole that we give? It depends upon the age of the child. If the child is less than 2 years of age, then 200 mg is given. Above 2 years, 400 mg is given. The single dose of albendazole is given. What about the third A? The third A stands for your vitamin A. Vitamin A, fat soluble vitamin, and one of the deadliest complication here in SAM is going to be vitamin A deficiency and night blindness. So prophylactically, you are going to give this vitamin A. What is the dosage of vitamin A? If it is a less than 6 months old child, then you give 50,000 international units. 6 months to 12 months, you give 1 lakh international units. Above 1 year, you give 2 lakh international units. And the catch is, if the child is above 1 year, but the weight of the child is less than 8 kgs, then you give half the dose. Usually, above 1 year, we give 2 lakh. But if the weight is less than 8 kg, then you give half dose, that is 1 lakh international units. So this is about vitamin A supplementation. The last A is appropriate vaccines. Age appropriate vaccines. You ensure that this child is vaccinated according to the age appropriate vaccines. So these are the 4 A's: antibiotics, albendazole, vitamin A, and age appropriate vaccines. And all of this nutrition and 4 A's are wasted if the child is not giving a nurturing environment. We need that the caregiver should give the adequate emotional support that this child needs. The child gets adequate play time, love and care from the mother, right? So particularly the caregiver. Caregiver should show emotional support, adequate emotional support to the baby. And lastly, home visits. Because we are sending the child home, we want someone to follow up the child, whether this child is actually getting adequate nutrition, whether this child is gaining weight or not, how is the child doing up, holding up. So for that, we associate with Anganwadi workers, ANMs, Ashas that do the home visits and weigh the child, take the anthropometric measurements of the child, assess the nutritional intake of the child. So for that, we take the helps of Ashas, ANMs, and Anganwadi workers. So this was all about the management of an uncomplicated SAM. Remember, this is an uncomplicated SAM. That means free of medical complications, free of edema, and having a good appetite child. But what about a child who has complicated SAM? That means this child has failed the appetite test. This child has edema. This child has medical complications. How you are going to manage that? This makes a major chunk of the questions that the examiner is going to throw at you. The examiner is going to ask you, tell me the 10 steps in the management of complicated SAM. Tell me the complications of complicated SAM. Tell me how you're going to manage hypoglycemia in a complicated SAM. Tell me how you're going to manage shock in a complicated SAM. So all of this that we are going to discuss over here. So brace yourself, have enough water beside you, because this is going to be a longer topic and an in-depth topic, because that is what required in your exam. Even if you open your Ghai textbook of pediatrics, you are going to find all of these details. I know they are harder to cram. There are a lot of values, lot of factual data, but the only way we can remember this by rereading again and again, understanding the basic concepts again and again. Right? So without further ado, let's start management of complicated SAM. So whenever you encounter a child with complicated SAM, what you're going to tell the mother? You tell the mother, we have to admit this child because this is a complicated SAM. Mother will ask, for how long you're going to admit? The answer is 6 to 8 weeks, depending upon how the child is behaving. 6 to 8 weeks. 6 to 8 weeks, you understand? Close to 1.5 to 2 months. So for that period, this child has to stay in the hospital. So you prepare the mother for that long duration. What you are going to do in these 2 months, 1.5 to 2 months? So the first week, we are going to stabilize the child. So this stabilization phase is for the first week. So in the first week, I am going to stabilize this child. So that means I am going to manage the complications of this child. And from second week onwards till 6 or 8 weeks, we are just going to now rebuild the wasted muscles of the child. So from second week onwards till 6 or 8 weeks, we are going to rebuild the wasted muscles. So the first week is known as the stabilization phase, and after that, from second week till 6 and 8 weeks, this is known as stabilization phase. The examiner can ask you what you do in the stabilization phase. You manage the complications. What do you do in the rehabilitation phase? You rebuild the wasted muscles of the child. Right? With that comes these 10 steps of the management. If the question is there 10 steps, copy this 10 steps. This is the same format that is given in Ghai. Okay. Raju, you're asking this much protein powder is dangerous. No, this is not dangerous for the child. Right? This child is malnourished, remember. This child needs protein. Remember, 4 to 6 gram per kg per day of protein. We will limit to that only. So stabilization and rehabilitation phase, 10 steps. Firstly, let's talk about stabilization phase. In stabilization phase, what we are doing? We are managing the acute complications. So in the initial period, in the first 2 days, we are going to manage the most deadly things. For example, hypoglycemia, hypothermia, dehydration. Manage initially in the first 2 days. What about infections? Can we manage infection in the initial 2 days? No, this infection will need at least a week of antibiotics. So infections over 7 days. Electrolyte imbalances, we never want electrolyte imbalance to happen, whether in the stabilization or in the rehabilitation phase. So electrolyte imbalances I will take care of throughout. What about micronutrient deficiency? Again, I'm going to take care of that throughout. And remember, iron supplementation is not started initially. Iron supplementation will be given in the rehabilitation phase. Why? We are going to discuss further. Initially, we start with cautious feed. This child is a complicated child. We don't want to bombard this child with a lot of calories and proteins. We have to be very cautious while introducing the feeds. So initially, we will start cautious feeding, and after that, we will catch up growth. Catch up growth, right? Love and care have to be given throughout. Needless to say, emotional support is very important. And once the child is in the stabilization phase, we plan for discharge and follow. So these are the 10 steps. Firstly, acute complications, hypoglycemia, hypothermia, dehydration have to be managed. Infections treated over the period of 7 days. Electrolyte imbalances and micronutrient deficiencies. Feeding, in which we start initially cautious feeding and then catch up growth. Lastly, love and care and discharge and follow up. One by one, we are going to pick up these topics. Each of these could be asked as a short note. Explain about the hypoglycemia in a SAM child. Tell how you're going to manage hypoglycemia, hypothermia in a SAM child. So without further ado, let's start with the first topic, that is hypoglycemia. So how do you define hypoglycemia in SAM? Hypoglycemia in neonatology, we know, is less than 45. But here in a SAM child, the hypoglycemia definition is less than 54. 54 milligram per deciliter. And if millimole you have to tell, then that would be less than 3 millimole. This is the definition of hypoglycemia. But if you have worked in a resource limited setting, government hospitals, then usually the glucometer is not available, or if available, it might not be working, or if working, strips might not be available. A lot of reasons could happen where you are not able to check the blood sugar levels. So if you're not able to check the blood sugar levels, assume hypoglycemia in a SAM child. So remember, if blood sugars cannot be measured, you assume that this child has hypoglycemia. Assume hypoglycemia. Right? With that, the examiner can ask you, what is the implication of this hypoglycemia? Remember, hypoglycemia, hypothermia and infection, they happen as a triad over here. Hypoglycemia, hypothermia and infection happen as a triad. What do I mean by that? If the child is hypothermic, most likely the child is going to have hypoglycemia and is more prone to infections. So you take care of the other two also. Goes vice versa for the other categories. So whenever we are treating for hypoglycemia, check the temperature. The child could be hypothermic also. The child is more prone to have infections also. So start antibiotics also. So this is the triad that we see. Now coming back to the topic, that is hypoglycemia. So I have a child, SAM child, whose blood sugars were reported less than 54. What I am going to do depends whether this child is a symptomatic hypoglycemia or asymptomatic hypoglycemia. What is asymptomatic? That means only the documentation of hypoglycemia is there. Otherwise, there are no symptoms of hypoglycemia. So that means this child is sitting well, but no symptoms of hypoglycemia, but the reported sugar is less than 54. So what I'm going to do over here, I'm going to give oral D10 to this child. So we give oral D10, 50 ml of the oral D10 we give. And after that, we start feeds. What feeds? We start with F75. This F75 feeds are known as starter feeds. We are going to read about in detail when we are discussing feeding. But for now, remember, after giving 50 ml of D10, we start these starter feeds F75. And this feed the child has to take every 2 hours, every second hour. And what is important over here is you have to ensure that this child is having these 2 hourly feeds in the night also. So if the child comes to you in the evening, you admit this child and start the starter feeds, what can happen? In the night, mother can doze off and sleep, and this child might miss 2 hourly feeds. So we have to ensure that this child receives the night feeds. Otherwise, the child can again land up into hypoglycemia in the night. So ensure the night feeds. This is all about asymptomatic SAM. What about symptomatic SAM? That means this child now has symptoms of hypoglycemia. This child could be either lethargic, child could throw seizures, child could be jittery, or could be sweating. All of the signs of hypoglycemia could be there. In that case, I won't give oral. I won't wait this oral thing to go down, get absorbed into the circulation. I would directly give IV D10. How much? 5 ml per kg. 5 ml per kg of D10 you give. After giving IV, I can now give oral. This oral can be given through nasogastric tube, or if the child is able to accept through mouth, then orally directly. How much D10? Again, 50 ml of D10 is given, followed by your F75 secondarily. So this is about the management of hypoglycemia. Now, how you are going to monitor whether this treatment is working or not? I will again check the blood sugar. After how long you are going to check the blood sugar? After starting off your management, you are going to check blood sugar every 30 minutes. Every 30 minutes, I am going to check the blood sugar till my blood sugar levels are above 54. Once the levels are above 54, then every third hourly you check. If on 3 hourly monitoring, the blood sugar levels come out to be normal again, you check 6 hourly. So remember, every 30 minutes first, then after 3 hours, then after 6 hours. So this is how you are going to monitor the blood sugar levels. So this was all about hypothermia and SAM. The examiner can very well ask you to write down a short note on SAM, the definition of SAM and the management of hypoglycemia and SAM. So this is what you are going to do. Okay, let's move to the next step, hypothermia. I told you hypothermia, hypoglycemia and infection happen as a triad. Let's talk about hypothermia. How you define hypothermia in a SAM child? So hypothermia is defined as axillary temperature less than 35 degrees Celsius or less than 95 degree Fahrenheit, or rectal temperature less than 35.5 or less than 95.5 degree Fahrenheit. This is hypothermia. This is how you define hypothermia. Bacha is thanda. Bacha is hypothermic. How are you going to manage? Firstly, cover the child. If it is winter season or not, you cover the child, cover the head of the child, cover the feet of the child, cover the hands of the child. So I'm going to cover the head by using cap, use socks, mittens. After covering the baby, I have to warm up the baby. The easiest method to warm up this baby is providing skin to skin contact, right? So we do skin to skin contact. Apart from that, the baby should not be very close to the door. The baby should be in an area which is in the corner. There should not be a free draft of air. So no free draft of air. The child's bed should be in the corner, not very close to the door where there is opening and closing and there is free draft of air coming. Then let's talk about the warmers. So usually we use overhead warmers. And in some situations, we can give warm feeds or IV fluids. So pre-warmed IV fluids or feeds. So this is how you're going to manage hypothermia. Now, like we were monitoring hypoglycemia, we are again going to monitor hypothermia. We're going to check temperature again and again. How soon you're going to check the temperature? The temperature monitoring has to be every 2 hours till the temperature comes down till 37.5. And once this temperature has been reached, then every 12 hourly or so you can monitor. And again, we have to ensure night monitoring, because in the night, again, hypothermia chances increases because of the temperature drop. So night monitoring has to be done. So this is all about your management of hypothermia. Now let's move to a very important topic, dehydration and SAM. So normal dehydration correction is different. Dehydration in SAM is different. How it is different? So remember, in the dehydration assessment in normal population, what are the signs that we pick up? We pick up skin pinch, we look in the eyes if the eyes are sunken. But here, what is happening in this SAM child? Overall fat of the body is very less. There is very less subcutaneous fat. So because of that loss of subcutaneous fat, my skin recoil is in fact very delayed. Right, so I overdiagnose dehydration over here. Also, the subcutaneous fat around the face is very, very less, so eyes can look sunken. So in SAM babies, dehydration is overdiagnosed. That's because of loss of subcutaneous fat. So what would be a good marker over here to checking the status of dehydration? We check the oral mucosa. You take the little finger and check the oral mucosa of the child, right? Or as the child to open up the mouth and look at the status of the mucosa. Mucosa is a good parameter to check, not your skin pinch or looking at the sunken eyes, because these SAM children do not have subcutaneous fat. So recoil must be delayed. So remember here, dehydration is overdiagnosed. Overdiagnosed in SAM because of loss of subcutaneous fat. What is a good parameter? Oral mucosa. Checking the oral mucosa is a good parameter. Right? If a SAM child comes to you with diarrhea, no brainer, assume dehydration. This child has dehydration, so assume severe dehydration. Now let's talk about the management of dehydration in SAM. Whenever you're talking about dehydration management in SAM, there are two principles that you need to take care of. First, overhydration is deadly. What do I mean by that? Once I have started hydration therapy, I have to keep a watch on this child. I cannot just attach IV fluid and let go. I have to be very watchful whether this child has overhydration or normal hydration. Why? Because if overhydration happens, what will happen? This child will land up into congestive cardiac failure. This child cannot handle excess amount. Dehydration is still safer, but overhydration, once the child has received a lot of fluid, there's no way that you can take out this fluid and this child will undergo congestive cardiac failure. So remember, overhydration is deadly. So you have to be very watchful while you're giving IV fluids or hydration therapy to this child. So overhydration is deadly. You have to be very watchful while hydration. And the second principle in the management is about the mode of rehydration. I can give IV fluids also. I can give oral rehydration also. Why? What mode I will use will depend upon the status of the child. If the child is in shock, I will give IV. If there is no shock, I will give oral. Right? So mode IV or oral, it depends upon the presence or absence of shock. Presence or absence of shock. So with that, let's start with dehydration management in SAM. Firstly, we are going to discuss the management of dehydration in SAM without shock. So without shock, I know I'm going to give IV or oral. Without shock, oral. So we give oral solution, that is ReSoMal. This is reduced osmolality ORS. Why we are going to give ReSoMal? Why cannot we give normal WHO ORS? Because remember, in normal WHO ORS, the sodium is very high. Sodium is 75. The SAM child cannot handle this much sodium. That's why we give ReSoMal. That is the rehydration solution for malnourished. Here, instead of dissolving 1 WHO sachet into 1 liter of water, I am going to dissolve it in 2 liter of water and add 50 gram of sucrose and 45 ml of KCl to it. This makes up your ReSoMal. How much ReSoMal this child has to be given? This child has to be given 5 to 10 ml per kg per hour of this ReSoMal up to 12 hours. So if this is a 10 kg child, I will give 10 into 10, 100 ml per hour for the next 12 hours. And along with that, with every loose stool, the child is going to getting a replacement of the ongoing losses, that is 10 ml per kg. 10 ml per kg. Again 5 ml per kg per loose stool. Okay, so if a 10 kg child comes to me, I'll tell the mother that for the next 12 hours you have to give 100 ml per hour, and within each hour, if the child is going loose stool, so for every loose stool you are going to replace 100 ml, again 10 ml per kg per loose stool. So this is how you're going to rehydrate the child. If the child is also receiving breastfeeds, do I need to stop breastfeeds? No. Then how can I give ORS or other things if the child is feeding? We do that alternate hour. So continue the breastfeed. If the child is getting ORS, let's say at 1 hour, 3 hour, 5 hour, 7 hour, then every alternate hour you are going to give feeds. This could be either breastfeed or your F75. This is how you are going to rehydrate this child. I told you that overhydration is deadly. You have to continuously monitor for hydration. Once you start hydration therapy, you cannot just sit around and scroll over your phone. You have to monitor for hydration. How are you going to monitor for the hydration? You are going to monitor 4 things over here. Firstly, the frequency of urine, frequency of stools, frequency of vomiting. If the child is getting adequate hydration, urine output will increase, the frequency of stools will decrease, the vomiting will decrease. So I have to monitor the frequency of urine, loose stools and vomit. You have to check the pulse rate. Pulse rate should normalize with the correction of dehydration. You have to monitor the respiratory rate. Respiratory rate will be normalized once the hydration is good. And you check the oral mucosa if it has turned moist or not. So all of these things you have to monitor. Initially in the first hour, you have to monitor every 30 minutes. Every 30 minutes for the first 2 hours of hydration therapy, you have to monitor every 30 minutes. And once the hydration status has improved, every hour for the next 4 to 10 hours. So this is the timeline. Unfortunately, you have to cram all of this up. This is the timeline how you have to monitor. Now, if while monitoring you see any of the signs of overhydration, you stop ORS immediately. So what are the signs of overhydration? If the pulse rate has increased by 15 beats per minute, if the respiratory rate has increased by 5 breaths per minute, if the edema of the child is increasing, if the periorbital puffiness is increasing, these all are the signs of overhydration. All of these signs are of overhydration. If any of these signs is there, what you are going to do? You are going to stop ORS. You are going to stop the ORS immediately. Stop the ORS immediately and reassess after 1 hour. Reassess after 1 hour. This is how you are going to manage SAM with dehydration without shock. Now the examiner will ask you what are the signs of good hydration. You already know what are the signs of good hydration. What will happen? My pulse rate and respiratory rate will come back to normal. Pulse rate, respiratory rate will slow down to normal. Urine output will increase. Oral mucosa will become moist. Eyes and tears will come back. Eyes will look now less sunken. And tears will come back, they reappear. If the child has good signs of hydration, now the child has hydrated, you can stop ORS here, but you continue the breastfeeding and ongoing losses. You just continue for the ongoing losses, replacement for the ongoing losses. This was about SAM with the dehydration without shock. Now let's talk with SAM with dehydration with the shock. So if there is shock, will you give oral fluids or IV? Here I will give IV fluids. And what is the choice of fluids over here? We give RLD5 or you give half DNS. RLD5 or half DNS, and whenever the child is in shock, needless to say, you have to start warm humidified oxygen. The rehydrating fluid, this RLD5, what amount you are going to give? We are going to give one bolus, 15 ml per kg of bolus. This you do not have to give rapidly. This has to be given slowly over 1 hour. And while this 1 hour, you're not going to sit and scroll over your phone. You have to continuously monitor because overhydration is deadly, right? So we continuously monitor pulse rate, respiratory rate, capillary refill time, urine output. If there is improvement, that means the pulse rate and respiratory rate has become normal. Capillary refill time has become normal, urine output has improved. If signs of this hydration are there, then whatever bolus that we gave, 15 ml per kg is working. So you repeat that. You repeat 15 ml per kg over next 1 hour. Over next 1 hour, and thereafter you start oral therapy, ReSoMal, same 5 to 10 ml per kg per hour, 5 to 10 ml per kg per hour. So this is when everything is going smooth, improvement is there. But if after that initial bolus of 15 ml per kg, over 1 hour there is no improvement, then you consider that this child has septic shock. You consider septic shock. So in that case, you have to manage septic shock in this child, and we all know what is the inotrope of choice in septic shock. That's noradrenaline. Noradrenaline. So septic shock, you manage accordingly. So this is about dehydration management. In dehydration management, we managed in two aspects. Dehydration with shock, without shock. Without shock, you're going to give oral therapy. With shock, you're going to give IV therapy. So with that, we have covered three important complications: hypothermia, hypoglycemia, and dehydration. Now let's move to infections. Normally, if infection happens to a child, the child will have seizure, fever, tachycardia. But these SAM children, SAM babies, they do not show the classical signs of infection. So they don't show fever, they don't show tachycardia. In fact, they turn cold. They show hypothermia. They show hypothermia. And majority of infection in the SAM children are by the gram-negative bacteria. So what do we do for that? We start empirical antibiotics in these children. Which antibiotics do we give? We give ampicillin plus aminoglycoside. It could be amikacin, aminoglycoside. So you can give amikacin, gentamicin. So usually ampigenta we give. So ampicillin plus aminoglycoside can be given. If after 48 hours of these empirical antibiotics, the child is not improving, then we upgrade to third generation cephalosporin. So if after 48 hours there is no improvement, we upgrade to third generation cephalosporins like cefotaxime. And if the child has any signs of meningitis or shock, you directly start with third generation cephalosporin. You don't start with amikacin and gentamicin. Okay, so this was small infection management. Now let's move to the electrolyte imbalances that we see in SAM babies. In SAM babies, the handling of sodium is haywired. So these children hold on to sodium. So these children hold on to the sodium. So with holding of sodium, water will also be held up. So the sodium will hold up water also. So overall, if you take the blood sample, because water is also there, I will see dilutional hyponatremia. Dilutional hyponatremia. So you can see in the blood sample that the sodium levels are less. But remember, these children cannot handle sodium. You don't need to give sodium from outside. We still have to restrict the sodium. This is the basic concept, right? So restrict the sodium. Don't give extra sodium over here. What is important in electrolyte imbalances is two major deficiencies that we see. Two major deficiencies are potassium and magnesium deficiency. So firstly, let's start with potassium deficiencies. Whenever you receive a SAM child, you have to send potassium values in all these children. We have to check serum potassium level in all the SAM babies. If the serum potassium is less than 2.5 milliequivalents, 2.5 milliequivalents, 2.5 milliequivalents per liter, or it is less than 3.5 milliequivalents per liter. Along with that, ECG changes are there. Then you have to supplement potassium in the IV fluids. Supplement potassium in the IV fluids. After IV fluids addition, if the child stabilizes, we will follow up with oral potassium. We add syrup KCl. The dose is 4 milliequivalents per kg per day. This you have to continue for 2 weeks. 2 weeks. Right, so this is about the potassium deficiencies that we see in SAM and how you're going to assess and manage that. Moving to magnesium. Magnesium levels are rarely done we straight away start with this magnesium supplementation. What dose that do we give? On day 1, you give 0.3 ml per kg, 0.3 ml per kg. Maximum you give 2 ml, or you give, you give 0.3 ml per kg, maximum 2 ml. This 0.3 ml per kg, if you have ever seen an ampule of MgSO4, this is 50% MgSO4. It has 4 milliequivalent per ml, 4 milliequivalent per ml. Right, this is a 2 ml ampule, so maximum you have to give 2 ml. And day 2 onwards, you give 0.8 to 1.2 milliequivalents per kg per day, of this 50% MgSO4. So for example, I have a 10 kg child, 10 kg. So what you are going to give on day 1? Day 1 it says 0.3 ml per kg, that becomes 3 ml, but maximum you have to give 2 ml. So this 2 ml I give intramuscularly on day 1, and after that I will give orally 0.8 to 1.2 milliequivalents per kg per day. So let's say 12 milliequivalent for a 10 kg child. That means 3 ml I will give afterwards orally. So this is about the magnesium supplementation in a SAM child. So that was the question that I gave, 10 kg SAM child dosage. So remember, on day 1 2 ml IM, and after that 3 ml you have to give. So this was all about the micronutrient major electrolyte imbalances. After electrolyte imbalances, let's talk about your micronutrients. So in general, remember nothing much over here. For micronutrient deficiencies, we ensure that this child receives twice the RDA. Vitamin A dosage, you know, what do we give? Less than 6 months, 50,000. 6 months to 12 months, 1 lakh. After 12 months, 2 lakh. And if the child is above 1 year of age but less than 8 kgs, 1 lakh. Apart from that, we give folic acid supplementation. The dosage is 5 mg on first day, day 1. And after that, we give 1 mg, followed by 1 mg. Zinc supplementation, we give 2 mg per kg per day. We give copper supplementation. Copper supplementation is 0.2 to 0.3 milligram per kg per day. Then we have iron supplementation. Iron supplementation, 3 mg, higher dose. We start 3 mg per kg per day. Remember, this iron has to be given in the stabilization phase. Why we give this in stabilization phase? Why not in the rehabilitation phase? In the rehabilitation phase, we don't give in the stabilization phase. The examiner asked why you're not giving it in the stabilization phase, why in the rehab phase you are giving? Because if I start this iron early on, it will lead to free radical generation, and it will also be a food for the bacteria. It will lead to bacterial proliferation. That's why once the child has stabilized, then only we add up iron. So 2 reasons why we don't give this in stabilization phase. Firstly, because there is free radical generation. And secondly, because of the bacterial proliferation. Right, so this was about micronutrients. Then let's move down to the feeding over here. Feeding. So when we talk about feeding in SAM, firstly we initiate cautious feeding. Initially we start cautious feeding. What do I mean by cautious feeding? This child is a complicated SAM child, right? I cannot bombard with a lot of calories and protein at once. What do we do? We gradually introduced small meals. Small but frequent meals. Normally you and me, what are the meals that we have? We have breakfast, lunch, dinner. In between breakfast and lunch, you can have a mid-meal, a snack. and then between lunch and dinner you can have a snack, and before going to sleep after dinner you can have a little snack. So total 6 meals, 3 major meals, breakfast, lunch, dinner, and 3 minor meals. But here I have to ensure small frequent meals every 2 hourly meals, right? So this feeding we start as soon as possible, and we give small frequent meals. If the child is not taking by mouth, I can try OG feed. If not taking from mouth, you can try through tube, that is OG, orogastric tube or nasogastric tube. And if the child is breastfeeding, I won't stop breastfeeding. I will ensure that the child is getting continue breastfeeding, right? Once we start feed, we start with F75. This F75 is known as starter feed. This you have to give every 2 hours. If the child develops diarrhea on this field, then I will give lactose free or low lactose. Initially, I give low lactose F75. If on low lactose also the child is not responding and the diarrhea continues, then we switch to lactose free F75. Now, what is this F75? F75, cautious feeding F75. What is this F75? For that, let's understand how many calories initially we are going to give. Cautious feeding, we have to be very cautious. So we start with 80 kilocalorie per kg per day, 80 kilocalorie per kg per day. And if the child is accepting it, we gradually increase this to 100 kilocalorie per kg per day. This F75 starter feed, the name itself has 75. So this has 75 kilocalorie per 100 ml and 0.9 gram of protein per 100 ml. So depending upon the weight of the child, let's say the child has 10 kg weight. So initially we have to start with what? 80 into 10, that is 800 kilocalories. So with that we titrate the volume. So this volume roughly comes out to be 11 ml per kg per day. This has to be given every 2 hours, and gradually we increase the volume. From 11 ml you can go to 20 ml, then 30 ml. So gradually we increase the volume, and as the volume is increasing, the feeding frequency will decrease. So increase the volume and decrease the frequency of the feed. This is about your starter feeds, cautious feeding. Once the starter feed is established, now you want to catch up. You have to increase the amount of calories and proteins. So in catching up, we start with F100. This F100 name itself has 100. So how many calories would be there in 100 ml? There will be 100 kilocalories in the 100 ml of this. Right? Proteins. What about proteins? In F75, the proteins were 0.9. Here the protein is 2.5 grams. 2.5 grams. How frequent you are going to give? I told you 6 meals per day. 6 meals per day. So here in the establishment, I have to start with 6 meals per day. How much volume? For example, if the child is accepting X volume in the first meal, now in the next meal, you are going to add up 10 ml. So X plus 10 ml, X plus 10 ml. And thereon, with each feed, you are going to increase the volume. If the child is breastfeeding, obviously you continue the breastfeeding. And if the child is gaining weight well on these feeds, then you shift to the normal feeds. That means home cooked meals or ready to use therapeutic fluid. So once the child is gaining weight, you shift to RUTF or ready to use therapeutic food or home cooked meals. Home cooked meals. Right? Now you will ask me, what is good weight gain, ma'am? When will I know this child is gaining weight well? So we have 3 categories of weight gain: good weight gain, moderate weight gain, and poor weight gain. What is good weight gain? If the gain of weight is more than 10 grams per kg per day, that is known as good weight gain. So whenever you notice good weight gain in this child, nothing to do. Whatever you are doing is working for the child. Continue the same treatment. CST, continue the same treatment. Second category is moderate weight gain. In moderate weight gain, the weight gain is 5 to 10 grams per kg per day. 5 to 10 grams per kg per day. In this scenario, what is happening? Weight gain is there, but it is not that good. So you check whether this child is having adequate intake or not. Whatever you are offering, the child is completely having that or leaving that some, right? So you check the intake of the child, you check the intake, whether the intake is fine or not. Check intake. And you also screen for infection. There could be some underlying infection, because of that the weight gain won't be good. So screen for infections. And lastly, we have poor weight gain. Poor weight gain means less than 5 grams per kg per day. In this scenario, you check for some latent infections. There could be some underlying infections like TB, HIV, or there could be some psychosocial problem, psychological problem. The environment of the child, the caregiver, and everything would be a limiting factor over here. So you screen for if there is some psychological issue or latent infection that can lead to this poor weight gain, TB and HIV. Right? Yes, Raju, I'm looking at your comments on the left side. Right? Stop spamming, please, or you will be banned. Okay, so let's start with the last point, sensory stimulation and discharge and follow. Sensory stimulation, I told you, if the child is not in a playful environment, loving environment, then the weight of the child won't grow. So I have to ensure that there is a cheerful and playful environment, and throughout the stay, the mother is offering food to the child with tender, loving care. So remember, cheerful, loving environment, playful environment, and tender, loving care. And WHO UNICEF has given a structured play therapy for these children. This play therapy has to be for at least 15 to 30 minutes per day. So for at least half an hour, the child has to be involved in that play therapy. That is shown to improve the weight of the child. Right, so this is all about sensory stimulation. Lastly, discharge and follow up. Now we have made the child, stabilize the child, rebuilding the wasting muscles. When you will discharge this child? The discharge criteria includes 4 points. The first point is about the weight of the child. So if the weight gain is at least 5 grams per kg per day, this is at least, it could be more also, for 3 consecutive days in the stabilization phase. If the MUAC has crossed more than 12.5 centimeter, or weight for height has crossed -2 standard deviation. Thirdly, this child should be absent from, just should not have edema. There should be absence of edema and good appetite for at least 2 weeks. At least 2 weeks. And lastly, there should be no complication. This child should be free from complications and receive the appropriate vaccine. So immunized for age. So these are the discharge criteria. So the examiner can ask you, what is the criteria for discharge of a SAM child? Good weight gain, at least 5 gram per kg per day for 3 consecutive days. MUAC crossed more than 12.5, or weight for height crossed above -2 standard deviation. Good appetite, absence of edema for 2 weeks at least. And lastly, this child should be free of any complications and has good appetite. This is the discharge criteria. Once this discharge criteria is met, you discharge the child, and on discharge you're going to give 1 tablet of albendazole. So on discharge you give albendazole. But sadly, not all children respond to the therapy, right? Some children fail to respond to the therapy. There could be primary failure or secondary failure. What is primary failure? That in this initial phase, in the stabilization phase only, the child is not responding. The child's appetite is not improving. The child is not losing the edema. What is secondary failure? In secondary failure, the child has crossed the stabilization phase. Now in rehab phase, the child is not gaining weight. Right? So let's understand primary failure and secondary failure. How do you define primary failure? The basic concept is that in the initial phase, the child is not responding. So it is defined as that by day 4, if the child fails to regain the appetite, this is primary failure. And if the child fails to begin losing edema. This is primary failure. And by day 10, it is said that by day 10, there should not be any edema and the child should be gaining at least 5 grams per kg per day. So by day 10, if there is still presence of edema and the child is not gaining at least 5 grams per kg per day, this is primary failure. Secondary failure comes in rehabilitation phase if the child is not gaining 5 grams per kg per day for 3 days. So rehab phase, the child is not gaining 5 grams per kg per day for 3 days. So this is about failure to respond to therapy. Lastly, we will wind up the SAM topic by discussing some complications that you see in rehabilitation phase. This could again be a short note. Write down the complications during rehab phase. 3 major complications the examiners ask. First is refeeding syndrome. Suddenly, a deprived child is receiving a lot of energy dense food. So high energy diet, that means high sugar in the body. To deal with that high sugar, what will happen? Body will produce more and more insulin. What this insulin does? If this is my cell under the influence of insulin, what happens? Potassium is driven into the cell. Phosphate is driven into the cell. Magnesium is driven into the cell. So what will happen? There will be hypokalemia, hypophosphatemia, hypomagnesemia. They ask what is the hallmark of this refeeding syndrome. Remember, the hallmark is this hypophosphatemia. Hypophosphatemia. This is refeeding syndrome. The second is nutritional recovery syndrome. What happens in this nutritional recovery syndrome? Because of high protein diet, the child develops hepatosplenomegaly, parotid enlargement, and ascites. Right? So there is ascites, hepatosplenomegaly, and parotid enlargement. Parotid enlargement. Then we have pseudotumor cerebri. In pseudotumor cerebri, what happens? There is, name itself has pseudotumor cerebri. There is transiently increase in the intracranial pressure. Nothing has to be done, just supportive therapy. So there is transient increase in intracranial pressure. Nothing has to be done, just supportive treatment, supportive therapy. So this completes a section of SAM. So Sutapa Samanta, stabilization and maintenance phase. I feel you have joined the lecture just now. We have discussed this long before when we started the management of SAM, that initially in complicated SAM we have the stabilization phase. Stabilization phase in which we stabilize the child, manage the complications, and then we have rehabilitation phase where we rebuild the wasted muscles. So if you go back, if you have joined just now, you won't get that concept. Right? So with that, we are done. We are done with the malnutrition section. Raju F75, we discussed this is the starter feed. Calories have 75 kilocalorie per 100 ml and 0.9 grams of protein. Starter feed. Initially, we start with this F75 and later on we build up and go to catch-up feed, that is F100. Okay, so if any doubt over here, please tell me now. Otherwise, let's move to the next topic, that is breastfeeding. Okay, primary and secondary failure. I told you that not all children respond to the therapy. Some children don't respond to the therapy. That means the child normally, what should happen? He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per day. He will be gaining 5 grams per kg per in the initial phase of our treatment, in the stabilization phase, when we are managing the complications, the child in that period should start losing edema, and by day 10 the edema should be gone. Also, this child should be gaining at least 5 gram per kg per day. If in the initial stabilization phase, the child by day 4 has not started eating well, there is still poor appetite, and the child does not start losing the edema, that would be primary failure. By day 10, if the edema is still there and there is no weight gain of 5 gram per kg per day, this is again primary failure. In secondary failure, the stabilization phase, the child did well, but now in the rehab phase, the child is not gaining weight, so this is secondary failure, right? So this is primary and secondary failure. Antibiotics, why are the antibiotics needed? I told you, hypothermia, hypoglycemia, infections, they happen as a triad. In uncomplicated SAM also, this child has enough nutrition, not have enough energy resources to fight infection. That's why I give prophylactic antibiotics. The measurement of appetite is by appetite test. How do we do the appetite test? If you look into the guide textbook of pediatrics, according to the age, we have certain ml or amount of feed. If that child is accepting that feed, that means good appetite. The child has passed the appetite test. If not, the child has failed the appetite test. Good appetite means it is an uncomplicated SAM. Poor appetite means it is a complicated SAM. Right? So with that, I believe we are done. If any other doubt is there, please let me know. Otherwise, we can wrap up this session. Okay, I believe now we can end this session. Thank you. Have a good evening. Thank you for being so cordial.